at Makerere. Dr. Mark Kadum Kasa is a senior lecturer in the Department of Medicine at Makerere University College of Health Sciences. And he's a physician at Mulago Hospital in Kampala. Professor Kadum Kasa has extensive experience in neurological disorders and rheumatology. In addition to his clinical work, he's an accomplished researcher and has also mentored several upcoming physicians. From this, you can see he actually comes across so many older adults, and we are going to have first-hand information from a researcher and a very active physician. Dr. Kadum Kasa, you're most welcome to this meeting. Before you, we have a mixture of attendees. Some are older adults, some are caregivers and friends, and they are not necessarily medically oriented. So we are happy to have you, and we believe you give us all the tips necessary for us to live with arthritis, a very common problem to all of us, whether we are young or old. You're most welcome, and you're welcome to unmute, greet the people, and you've got the next 30, 40 minutes to tell us all about arthritis. Thank you very much. As Dr. Kadum Kasa is coming on, members, you can put any questions, comments in the chat room. And at the end of the 45 minutes presentation, we'll have questions and answers. And you are all invited to participate, whether through the chat room or by putting up your hand. This session is recorded, so any of you, okay, here we are. Doctor is on. Doctor, you're most welcome, and the floor is yours. Good morning.
Good morning. Thank you, Ms. Christina Mukwanya, for the wonderful introduction. I was actually trying to share my slides, but looks like it is disabled. So I don't know how I can.
Maybe you go forward. You could try and share again.
Maybe she needs to stop sharing.
Yes. Moderator, please stop sharing so that the speaker can share. Alternatively, can you send me your slides on email? Let me just post my email in the chat.
Okay, let me do that.
I hope you have seen it now.
Yes, I have.
Okay.
I've sent it. So maybe
Right.
when you receive it, you can share.
Okay, let me refresh.
Yeah, as we wait, I think for the listeners and the organizers, thank you for allowing me to say a few words regarding arthritis. We know that arthritis is a common problem, especially as we age. I'm going to stop my video, but I'll keep on talking. So arthritis is a common disorder which we face, especially as we grow old, and it affects our quality of life, our activities of daily living, and increases the risk of us getting other complications, especially with the known NCDs, which require
I'm sorry, just interrupt. I still haven't got the email. Maybe just recheck that you sent to the right email. It has a single L and double P in Philippa.
Yeah, it's philippakm@gmail.com.
Yes, Philippa with a single L and a double P.
Yes, double P, yes.
Okay.
And here it shows that it was sent. So it should be somewhere between here and
It is somewhere playing us. Okay.
somewhere in the airwaves, but should be coming.
Okay, let me wait. Thank you.
So arthritis affects your activities of daily living and takes away a lot of your ability to enjoy your retirement, enjoy interacting with your colleagues, with your family, the young ones, and it also has economical implications, especially that you're spending money when you are retired to meet the costs and other hospital-related costs. So it is really a problem, but okay, so I'm able to share.
Oh, you're able to share.
Yeah.
Okay, good. Yeah.
So let me. Okay. So today we are just going to talk about living with arthritis. I'm Mark Kadumkasa, and I hope I tried to make it as simple as possible for everyone to understand and follow. And we are going to talk about the general information, the common types of arthritis, then strategies in self-management. So arthritis is a very broad term, which mainly tells us that our joints are swollen, they are inflamed. You can have joint pain without swelling, and we refer to that as arthralgia, not arthritis. So arthritis refers to inflammation of the joints. And we have over 100 rheumatic diseases or conditions, which typically affect the joints, the tissues which surround the joint, and other connective tissues. These tissues which help to support your movement. So the pattern, the severity, the location depends on the type of arthritis you have. And typically, patients who present with arthritis have pain as well as stiffness in one or more joints. And we have seen that these symptoms can develop gradually over time. They start when you're still young, active, and they continue, or they can come on suddenly after either trauma or after an infectious process. You get an infection and you develop arthritis. And it is also important to know that some of these diseases can involve other body systems or organs, not only the joints. So how common is arthritis in the world? In Africa, there's limited information on arthritis. Most of the data we have is limited reporting from hospital studies or small communities or small sample sizes. We have never had a nationwide survey to determine the burden of arthritis in Uganda. Likewise, in Africa, there's limited information. Most of the information we use is from developed countries like the US, which have conducted nationwide studies. And WHO has reported that disability associated with arthritis has increased by 45%. That is from the year 1990 to the year 2010. And the commonest type of arthritis we see is osteoarthritis, which typically involves the big joints, as we shall see, and it has been ranked as second cause of disability by WHO. In the US, there are about 400 million, but about 8.8% of the US population report that they have arthritis or arthritis-related activity limitation. That was in 2003. So this graph shows the prevalence of arthritis, and of note is the top most part of the graph, which is in, well, men are colorblind, but I would say that is orange, though even the one which is down looks to be orange, or a little bit reddish orange. The one on top shows the people who are aged 65 years and above. But you see that their numbers have gradually increased over the years from nearly maybe 11,000 to now about 18, nearly to 24,000. This is in the US. So you see that as we age, we tend to shoulder most of the burdens of arthritis compared to those who are aged 18, the yellowed down 18 to 44 years, which has remained relatively stable over the years. In Uganda, we don't have this kind of information to give you that true picture. So which category of people at risk of developing arthritis? And here you see it is mainly the elderly. And for elderly here, we take 65 and above. In other countries, it has been racial, or in ethnic minorities. In the US or in the Western world, it's mainly the Blacks and Hispanics, especially those who are the lower strata of economic empowerment. They tend to be a high-risk group. Females, typically some of these autoimmune diseases are more common in females as compared to males, as we shall see. Then people who work in certain occupations where they involve a lot of use or movement of the joints, especially the construction workers, professional athletes, textile workers, teachers, and dancers tend to be at high risk of developing arthritis. We have seen that as we grow old, the chances of us being diagnosed with arthritis increases. 50% of those who are aged 65 or more have been diagnosed with a type of arthritis. So that is age. And this slide shows us that as we grow old, overall, the prevalence of physician-diagnosed arthritis increases with age. And we have seen that females, the ones which are in lighter blue, tend to be more diagnosed with arthritis as compared to the males in the blue. And this increases over time, and you see that it's peaking at around 85 years. So what causes arthritis? So there are many causes of arthritis, but I will focus on ones which are important for our presentation today. Different causes or different diseases have different causes, but overall, we don't know the single cause or etiology of arthritis, but we have theories, we have explanations for some of the arthritis. And we have seen that people who are overweight, especially as we grow old, we tend to put on weight. That predisposes us to some of the types of arthritis, especially osteoarthritis, which is the commonest. We have seen that people who overuse the joints, repetitive joint use for professional athletes, factory workers, teachers who keep on standing the whole day, increase the risk of developing hip or knee osteoarthritis. Injuries or trauma, you disrupt the normal anatomy or the normal structure of the joint, then you increase the risk of developing a degenerative type of arthritis. Physical inactivity, you spend most of your day sitting, watching TV, you don't move, then you increase the risk of getting arthritis. Then, of course, genetics. There are some genes that have been reported to increase the risk of developing certain types of arthritis in some populations. Typically, arthritis is associated with other non-communicable diseases, which may either become worse or may make it difficult for us to exercise, hence increasing the disability associated with arthritis. So heart disease, chronic respiratory conditions, diabetes, stroke, lipid abnormalities have all been reported to be associated with arthritis. And this is data from the US. We don't know how bad our patients in Uganda are suffering with these common non-communicable diseases. I think we need to study that to try and develop interventions targeted to improving their quality of life. But from experience, majority of them still have hypertension, diabetes. Some of them suffer from strokes, as well as hyperlipidemia. And that also kind of limits their ability to participate in physical activities. So we have seen that there are over 100 types of arthritis. And for this presentation, I will focus on 5 common type of arthritis in the elderly population. And number 1 is osteoarthritis, followed by rheumatoid arthritis. Then we have post-traumatic arthritis, gout, and we'll also talk briefly about osteoporosis, which affects the elderly population. So osteoarthritis is the commonest form of arthritis in our populations. Usually it starts when we are above 45 years and older. And typically it tells you that the protective cartilage at the end of the bone in the joint has worn out. It has degraded. And mainly it affects the knees, the hips, the hands, and the spine or the back. So patients will come in with pain, knee pain, hip pain, pain in the hands, or lower back pain. And when we examine them, we will find that there's tenderness or there's pain when we apply a little pressure. They develop stiffness. I can't stretch my leg properly, or when I'm walking, I feel my knee is locking. It gets stiff for a few minutes, then I have to sit and wait, then it gives way. We call that gelling. Sometimes they feel
Hello, Prof. Kadumukasa. We seem to have lost you.
that they sounds a grating feeling. When we do x-rays, we have and other characteristics. Smooth cartilage there in gray, and the blue is the synovial space with fluid. On the right, you see that the cartilage has been eroded. It's gone. It's no longer there. It's irregular, and it's the one which causes that gritty feeling when you walk or when you exercise. So osteoarthritis, of course, we have seen increases as we get older. It's more common in men than in females when they are less than 45. But as we grow older, usually the women take over, and it's more prevalent in women after the age of 50, 55. It's more common in blacks, as we have seen, as compared to whites. I think for us blacks, we know that as we get more money, we put on more weight. We think that putting on more weight represents status, that you are rich, you are eating well, you are eating junk. So that increases the risk of wear and tear. We have said risk factors include joint trauma, obesity, repetitive joint usage, and it's associated with muscle weakness, especially for the knee. People tend to lose the size of their muscles. The thigh muscles become thinner, and you'll see that when you feel just above the knee, that muscle has retracted and you see a depression. So that makes it difficult for you to support the upper body, because now all the weight has to go through the knee. It's no longer carried by the muscle and the ligament or the tendons over the joint where it inserts. Then, of course, nutritional deficiencies, low calcium, low serum vitamin D levels have been reported in people who have osteoarthritis. We had a study in Mulago in people who had osteoarthritis, and nearly 30 to 40% of women and men who had osteoarthritis had low levels of serum vitamin D3, which we get from the sun. And when it goes down, it interferes with the way the body repairs the bones and other tissues surrounding the joint. So risk groups for osteoarthritis, we've seen genetics, and these people tend to have swellings, Haberdine and Bouchard's nodes in the fingers, especially at the last joint in the fingers. People tend to get those small bumps or swellings or nodes, which may be painful at some times. That is due to genetics. Then sometimes it's due to the inborn deformities. People may have a congenital hip subluxation that increases the risk of developing osteoarthritis. If you suffer from other inflammatory joint diseases, you have rheumatoid arthritis, you have other types of arthritis, which are inflammatory, then you increase the risk of developing osteoarthritis. Because of the inflammation, you kind of damage the cartilage. Then metabolic disorders, commonest is hyperthyroidism, as well as diabetes. Osteoarthritis it has a low risk of death. It's not common for you to die from osteoarthritis, though it kind of affects your daily activities or your quality of life. You don't enjoy, you can't move, you are in pain, but the risk of death is low. In the US, it's about a 0.2 to 0.3 per 100,000. It increases the risk of hospitalization. Nearly 50% of people who are admitted because of arthritis, it's due to osteoarthritis, and it's mainly because of knee and hip joint replacements as we grow old. And these are expensive procedures, and they have increased over time. Now, it's something we think about or we need to prepare for as we age to improve our quality of life. And those are the estimates which have been reported. You see they are in billions of dollars. That is for knee and hip replacement in the US. Here we don't have the cost figures for the annual joint replacements in Uganda, but maybe we'll need to engage the orthopedic surgeons to try and estimate that. Next, I'll go to post-traumatic arthritis, which results from wearing down of a joint after an injury to the joint. So you can sustain an injury as an adult or as a child, and 10 to 15 years down the road, because of that injury, you develop arthritis. You develop pain, swelling, fluid accumulates. And typically it also involves the big joints, the knees and the hips, and may be similar to osteoarthritis. Usually it is as a result of contact sports or physical labor, may occur as a result of accidents or past joint surgery. We have seen patients who go for laparoscopies or joint surgery following accidents. Later on, may develop post-traumatic arthritis. Looks like osteoarthritis. Next, I will talk about rheumatoid arthritis, which is a chronic inflammatory autoimmune disease. Typically, it affects all body joints, but more especially the small joints in the hands. It involves the wrists, the elbows, and the ankles. Tends to spare the big joints, the knees, the shoulder, and the back. Patients will present with joint swelling, stiffness, and pain, and other systemic features. They may have anemia, they may have lung involvement, liver, and we make a diagnosis by checking their blood, confirming presence of some antibodies in their blood, which lead to the disease attacking their synovial membranes, and it subsequently leads to deformity if not treated. You see the one on the left is a normal joint, and the one on the right, you have bad arthritis. It has eroded away the synovium, destroyed the bone, and it leads to deformity. As you see the picture of the hand on the right, you see the hand, the fingers are deviated, they are deformed. So that is typically rheumatoid arthritis, and we can treat it. It is estimated to affect about 1% of the general population. It increases with age. It is more responsible for more mortality as compared to osteoarthritis because it involves other body organs. It can affect the lungs and the GIT. It has been associated with smoking, and smoking is a strong modifiable risk factor for rheumatoid arthritis. There's a role of genetics. We see that it increases with age. Usually it peaks at about 60 years. There's no difference between races. It affects blacks and whites in the similar way. And we have seen that it's more common in women than men. So up to about 3 women out of 10, or you can say that out of 10, you can have maybe about, for every 1 man, you have 3 women affected by rheumatoid arthritis. Data is lacking. You see here, we are talking about the...
What is lacking?
Hello?
You mean the bread?
Hello, can I continue?
Yes, sorry, we muted him. You can continue.
So this one is just showing the DALIs, and you see that the US, where there's data, and Europe, people have their they have a lot of disability associated or arising from rheumatoid arthritis. That is between 40 to 100 per 100,000. That is yellow to red. And Africa, these are estimates, but we don't have the correct figures. So probably you might find that our DALYs or our rates for the DALYs are much higher than in other developed countries because of limitations in treatment, provision of medicines, and other associated care. Then the fourth disease I will talk about is gout. Gout is a metabolic disorder, and it's usually associated with high levels of uric acid in the blood. And typically, if you have high levels of uric acid, these crystals are deposited in the joints. That deposition subsequently leads to pain and swelling. It typically starts off as an acute disease and can progress to a chronic disease. Usually it starts off in the big toe where you deposit the uric acid crystals, so the toe will swell. You go for a party, end of year party, or a wedding, you eat a lot of meat, take some wine or beer, and you go to bed when you're okay. Then during the night, you wake up with bad pain. You don't want even the bed sheet or a cloth to touch your joint. Then we know that that is gout. Of course, we confirm it with a lab test. We confirm that it is uric acid. We have other diseases where you can deposit crystals other than uric acid in your joint, and it can also present like that. This one on the right is showing a swollen finger. It's very painful, increases with age. We know that it is a known risk factor for heart disease or cardiovascular disease. So you need to take care of it. We don't have data in Africa, as you see. The brown, I think Nigeria and Ghana have some little information. But you see, this is Burkina Faso, the one which is blue here, and its prevalence is similar to the prevalence in the US. More than 4% of the adult population have gout. More common in males than in females. Maybe the males tend to be selfish and eat a lot of meat or take a lot of beer compared to the females. It's more common in blacks than whites, and we have seen that it increases with age. So mainly there are some genes that have been reported, which kind of affect the way the body handles proteins and excretes it or gets rid of it from the body. It is associated with obesity, alcohol consumption. I think either Thursday or Wednesday, newspapers showed that Uganda is leading in alcohol consumption. People tend to eat a lot of meat. We don't eat a lot of seafood because we are not near the sea, but people tend to eat a lot of goat's meat, pork. You are one person and you sit on a lusania of pork and you finish it. It increases your risk of getting gout. Then, of course, occupation and environmental lead exposure. Lastly, I'll talk about osteoporosis. Osteoporosis is when your bone becomes weak, it softens. And we know that we tend to develop our bone mass as we grow, and it peaks at about 20 to 25 years for females, and about 28 to 30 for males. Then after that peak, it starts reducing as we grow old. So if we don't maintain our bone mass we have attained during young adulthood, we increase the risk of developing osteoporosis and developing fractures, especially for the spine, the hip, the wrist, and other bones. You are in your shower, you are bathing, you slip and fall, or you're climbing downstairs, you slip. You slip and fall, then you end up with a fracture. We know that that is due to a weak bone. It increases with age, and it is an expensive disease. I think this is my last slide, and it shows the projected number of osteoporosis fractures worldwide. Africa doesn't have, we have no estimates, but you see that overall globally, the green is the projected number of fractures attributed to osteoporosis. Everywhere they are increasing. In the US, up to 763 per 100,000. The highest increase is in the Southeast Pacific or Asia, where it's moving from 500 to 3,000. So we need to prepare for those fractures. So known risk factors, genetics, yes, especially for people who have genes that affect vitamin D metabolism. We know that estrogen, when you osteoporosis, then this collagen. Collagen is one of the tissues, or one of the things we find in the joints which help with bone formation. Physical inactivity, if you're not active, you don't stress your bones, they become weak. Low body weight, we have seen that if you're obese, you have a higher risk of getting other types of arthritis. Now, if you have less body weight, you don't stress your bones enough, you have a high chance of getting osteoporosis. Smoking, alcohol, then of course aging associated with osteoporosis. We have seen that it is more common in women than men. It increases with age. We have seen race plays a big role. In the previous slide where I showed South East or South Pacific areas, in Asians, I think because of their body morphology, they tend to be smaller. They are at a higher risk of developing osteoporosis compared to the whites and blacks. So how do we prevent these kinds of arthritis? For osteoarthritis, we have seen that repeated joint injury or joint use increases the risk. So avoiding joint trauma can help. Normal body weight by avoiding obesity. Then modifying occupational joint stresses. If you are a professional athlete, you are running a marathon, you need well-cushioned shoes, and you watch the way you run. Gout, we have seen the causes. You need to have dietary changes, weight reduction, then moderation or elimination of alcohol. For osteoporosis, make sure you take adequate levels of vitamin D and calcium during childhood so that you put on a substantial amount of bone mass as you grow. Usually it peaks past adolescence. So make sure you have enough bone in the store such that by the time it peaks and it starts going down, you already have enough. You need to stop smoking, then hormonal therapy for postmenopausal to increase your estrogen levels. Then, because there's an increased risk of falls as we age, because our muscles are weaker, we are a little bit frail, you can fall-proof your areas by putting on cushion instead of putting on tiles in the bathroom or in the sitting room. You can put carpets or areas where you minimize putting cushion when you fall. Secondary intervention, make the diagnosis for osteoarthritis early and initiate interventions. There are proposals to start initiating treatment for elderly people who have asymptomatic hyperuricemia. We have seen that high levels of uric acid can also affect your cardiovascular system and the kidney. For you to detect osteoporosis early, we recommend a bone mineral density testing done. We do a DEXA scan, which can be done for women aged 65 and above or men 75 and above. It is available in Muju, though it was mainly for research. But we have other tools we use. We have the calcaneal bone density ultrasound, which gives us an estimate. Of course, it's not as good as the DEXA scan, but it gives us a good estimate. And also taking precautions if you have a history of fractures. Then individual care or intervention, making the diagnosis and initiating treatment. There are various drugs we give for specific types of arthritis, but overall we use painkillers, we use steroids. Remember that steroids can increase the risk of osteoporosis. We have a number of drugs we use targeting different molecules in the immune system. Then we have the non-pharmacological treatment, physical therapy, physiotherapy, exercise, or muscle strengthening activities. You can set up support groups for people who have arthritis. We have a support group, the Arthritis Association of Uganda. There's the Lupus Association of Uganda. So all those offer support for people who have a specific diseases. Then, of course, surgery. You need specific surgical interventions. Then don't forget that you can also look after arthritis. And this can be done by the patient or caregivers. So you need to arthritis. Of course, we know that it causes become depressed because activities you used to do. You need to have exercises, simple exercises. Walking is our recommended exercise. Then, of course, use your medication appropriately and take them when needed. They have associated side effects. NSAIDs increase the risk of ulcers. They can affect your kidney. So use them appropriately. Don't self-prescribe. Communicate effectively with your family, friends, and health profession. Let them know that you have some limitations and there are some activities they shouldn't expect you to participate in, or they should encourage you to participate in, or should support you in certain activities. So communicate effectively. Then, of course, maintain a healthy nutrition as well as sleeping habits. Participate in making informed decisions regarding your health. Then you need to learn how to solve problems to address certain obstacles which are specific to arthritis. So things like using canes, walking aids, how to manage the pain. All those are available in the self-management activities or approaches for arthritis. So overall, we recommend that you do strengthening exercises even at home, especially for the major muscle groups, the legs, the hips, the back, abdomen, the chest, shoulders, and arms, at least 2 days a week. And for strengthening exercises, we refer to carrying a little weight. Or when you do exercises, you can involve a little weight, maybe 1 kilogram, 500 grams, to support your muscles. We have seen that when your muscles become weaker, then the risk of disability increases. So as you exercise, involve some weights or carry some things to support your muscles. It is recommended that we do about 150 minutes of moderate intensity activity or exercise, or 75 minutes of vigorous intensity activity in a week. That is a WHO recommendation. So that means you can do 30 minutes every day of moderate intense activity, and that will equate to 150. And by vigorous, we mean that when you are doing the exercise, maybe you're running or jogging or skipping, you find it difficult to have a conversation comfortably with someone or talk on phone, then it means that is vigorous. So that one you tend to do less vigorous activity, 75 minutes. Spread your exercises evenly throughout the week. Don't do all the 150 minutes in one day. Reduce the time spent sitting or lying down by moving around. And some of the activities which we consider to keep you happy include gardening. It could be cleaning, washing dishes. So all those work or household activities or housework also support you and help you to strengthen your body. So that is all I had for today. So I will have a few questions or comments or concerns, and I open up the discussion. Over to you, Chair.
Thank you very much, Professor Kadumukasa. It's been very enlightening. I'm sure many of you, especially the caregivers, have now got a better picture of how to handle the seniors, the elderly. You know what exercises you can take them through, and how much of it and what food to eat. Thank you so much. Now we are going to open the session to some questions. And I would like to ask Dr. Philippa to take us through the comment question time. Dr. Philippa.
Thank you very much, moderator, and thank you, Professor, for the presentation. We already have some few comments and questions. I think the first comment was someone mentioning a direct attack on Lusania. This person clearly loves their pork or goat's meat and is going to have to make some modifications to their diet, it seems. So the first question was about treatment options. What treatment options are available for people who may already have deformities due to arthritis, for example, deformities in the hands? I'm going to read like two questions, and we'll let you answer as we wait for some more. And the next question was, do you recommend a BMD for people younger than 65 who may be at risk due to other factors? The third question, thank you, Professor. Can you comment on gout in females, please? We could take those questions and then we'll give you another set after that. Thank you.
Okay, thank you, Philippa. Just another comment regarding gout before I respond to the gout in females is that just know that gout is, your body is not handling well the protein load. You're overloading your body with protein. So protein is also broken down, and one of the end products is uric acid. And you need to know that all types of protein can increase the risk of gout in someone, not only red meat, but even white meat. If you overindulge, you eat a whole piece of a whole chicken, those are somersaulting chicken, or people call them TV chicken, something like that. Just everything, just do in moderation. I've had patients who have switched from meat and they eat peas or beans, but remember that even peas and beans are also protein. So if you eat a lot, they can also worsen gout. So remember that. So everything you do in moderation. Remember that as we grow old, our body kind of also doesn't handle well everything we give it. It slows down a little bit. So we also need to slow down in what we are giving our body. Then gout in females, yes, females can also get gout, but it's more common in males. Presentation is the same and treatment is the same, but it's more common in, I think, males. Maybe when they go out, they tend to eat or drink more beer, eat more meat as compared to females, probably because of the cultural aspects or cultural beliefs. Women shouldn't eat chicken and other things. So maybe that's why they're a little bit spared, but they are also affected by gout. Deformities due to other types of arthritis, rheumatoid arthritis. So depending on the severity, we work with the orthopedic surgeons. They can carry out repairs or reconstructions to reduce the deformities and try and preserve joint function. So sometimes patients can have subluxations, their tendons can rupture, they can have dislocations. So the orthopedic surgeons can repair that and try and preserve the joint function. Yes, we have a role of surgery in deformities. Then sometimes there are deformities in osteoarthritis. You have seen people who have their knees or their legs bend. They are, in medicine, we call it varus or valgus. It's called, I forget the English word, oxbow or something like that. Yeah? They are bent. So we have devices or braces which we can put at the joint or tie at the joint, which we call the loading or unloading braces, and they try and correct that deformity. Even there, surgery can help. Of course, joint replacement is an option. Then the third question was recommendation of a BMD for people who are less than 65 years. Yes, we can do that depending on the type of condition the patient has. We have seen some drugs, especially for people who have been diagnosed with HIV. Some of the drugs can lead to their bones becoming weak. And yes, we recommend for BMD, especially if they are less than 65. Then other disease conditions, BMD can be done depending on the diagnosis your doctor has made and what other comorbidities or other disease conditions you have. This can be done. Over to you, Fiupa.
Okay, thank you. The next is a question and comment from Agnes, who says, I have bad arthritis and do all those exercises, eat food as recommended, but still arthritis is bad and it's painful. What else can I do? The next is Anna saying that, thank you for your presentation. Her question is on lifestyle choices like wearing high heels. My question is, do lifestyle choices like wearing high heels cause arthritis? I personally love high heels and in my mid-30s. So you comment about that. Then another one about, wow, great presentation. Menopause is an issue for us older women as it triggers osteoporosis. Do we have HRT in Uganda where we can review perimenopause or in menopause? You can handle that. Another was a comment on Molokoni. The next question is, my hands look like the one in the picture, one of the photos you showed, but X-rays show that joints are normal. Can that be treated to become normal? Right. You could handle those and then we'll take the next set of questions.
Thank you. So I'll start with the one of bad arthritis. So there are many types of arthritis. I don't know which type of arthritis you have. I think what you just need to know is that we do not have a cure for all types of arthritis. So some of them, especially the autoimmune inflammatory types of arthritis, rheumatoid arthritis, SLE, the other types, spondyloarthropathies, we don't have a cure, but we have drugs which can control or bring it into what we call remission. Remission is where you are able to live your normal life. You don't have pain, you don't have swelling, as if you're a normal person, but you keep on taking drugs to remain in that state. If you stop the drugs, the arthritis comes back. So I don't know which type of arthritis you're talking about, but I think what you can do is to go and see your primary doctor, and they can recommend changes in the drugs they're giving you, such that they can control that bad arthritis and you live a normal life. Exercises and eating food alone may not control the pain and the swelling. So you may need other interventions. Then for the one regarding lifestyle choices, high heels, yes, high heels, I know people like them, but if they are very high, they kind of put stress on the ankle and the foot and strain it. And later on, as you age, you might end up with arthritis. You might end up with heel pain, ankle pain, foot pain, resulting from the high heels. So take precautions. We actually recommend that you don't put them on all the time. And the best shoes are the ones which are well cushioned and they have arch support. You've seen those shoes where you have, especially the ones we use for sports, they have an arch support, and that arch support prevents you from getting flat feet. If you get flat feet, then you have deformed your normal architecture of the foot, and later on in life, you'll end up having foot pain. Especially you step down, you walk, and that affects your activities. So take some precautions. Menopause, yes, menopause does occur. HRT or hormone replacement therapy is available, especially if you work with your gyne doctors, they can provide it. And they also try to follow up with the associated side effects, which might be things like you may get your premenstrual symptoms, bloating, tender or enlarged breasts, because they're giving you drugs which contain hormones which have reduced in your body. So you may get some of those side effects and putting on weight. So you need to see your gynecologist and you discuss that. The drugs are available and they can help control osteoporosis. Molokonyi, I've had quite a number of patients who have been recommended to eat molokonyi for osteoarthritis, but it doesn't work. It only increases the risk of obesity or hyperlipidemia, or increasing your serum fats. So don't overindulge or overeat molokonyi thinking that it's going to take away or make your osteoporosis go away. No, it will not. Eat it if you must, if you like it, but don't take it because it is a form of treatment. We have, the thinking was that if you eat foods which are rich in the constituents or things which make up the joints, your chondroitin sulfate, glucosamine, then probably you're going to help the body, or you're going to provide the body with the ingredients to repair the joint or the cartilage, but that has not worked. Similarly, we have a number of joint drugs, osteocare, osteomine, osteoflex, chondroitin sulfate. There are so many supplements. And research has shown that they are not very good, or people who have taken them have not got the desired effects, yet they are quite expensive. We have also had injections. I've injected in patients Orthovisc, Visc, but the response is not as good as anticipated. So maybe we're not doing, or we're not giving you the right drugs or interventions for the osteoarthritis. And yet these are expensive drugs, which you are going to continue taking nearly for the rest of your life. So I don't personally prescribe them. I only request you to eat a normal healthy diet and exercise. Then the other question was regarding deformities in the hands, yet the x-rays are normal. If some people can have deformities when they don't have arthritis. So if the x-rays are normal, you don't have pain, you don't have swelling, then you don't need to worry. We have various forms of diseases. Some of them may lead to deformities or malformations, but without causing pain. We may also have deformities arising from our genetic, the way we are born. It does not necessarily mean that we have disease. So as long as there is no pain, no swelling, I wouldn't worry. I know the cosmetic issues. The danger is that sometimes when we do surgery to fix the deformities, we kind of affect the joint. So you may have a normal looking hand, but you lose the ability to flex or bend your fingers. So that is a danger you may run into if you go for surgery, especially if they are doing, we do joint fusion. We fuse the joints, so you lose the ability to use your fingers. So see your primary doctor, discuss about the options. Then you can also discuss with another. Thank you.
Okay, there's a question on how to reduce the uric acid levels, which Agnes believes is the cause of her very high, rather is responsible for her joint pains. And then a question on does any pain on the knees point towards arthritis, especially when climbing down the staircase? And there's a question about, is there any link with the gut microbiome to arthritis? And another one saying, I have arthritis, female late 40s, and occasionally get swelling in my right ankle and right elbow. I exercise and changed my diet. I have ulcers, so I have been advised to stop eating ginger and garlic. When I don't eat these two, the inflammation is frequent. You comment on that one. The other is, I've heard someone mention beans as a trigger for her arthritis. When they eat beans, they get the pain. Can you speak more about other foods that one can avoid if they have arthritis? Then the next is it okay for anyone with any of the mentioned types of arthritis to use food supplements? Are supplements safe, especially for rheumatoid arthritis? And then what is your comment on joint pain and swelling in the elderly attributed to kabotongo? Is there a benefit in physiotherapy using local herbs? Many caregivers with no access to drugs, etc., resort to this local treatment. Right. You have broken my heart on Molokonyi. All along, I thought it was helpful. Thank you for busting that myth, Professor. Over to you to handle the questions.
Yeah, thank you. Quite a number. Uric acid, I'll start with uric acid. Yes, there are drugs for treating high levels of uric acid. And I've told you that uric acid comes from loading your body with lots of protein. So technically, by reducing your protein to the desired levels, you can address the issue of uric acid. And we have seen that you can do that by reducing the amounts of meat you eat, especially red meat. You can switch from red meat to white meat, chicken, fish. Yes, their protein is not so bad in producing high levels of uric acid. We have seen that for some people, when they eat a lot of beans, peas, they can precipitate an attack of gout. So the trick is doing everything in moderation. Don't overindulge. Take 1 or 2 pieces of meat, that should be sufficient, instead of eating half a kilo of meat or a half chicken half piece of chicken or something like that. Pain in the knees. So there are many things which can cause pain in the knees. So yes, walking downstairs, climbing stairs, squatting, kneeling, usually those ones point to osteoarthritis. And when you stress the knee, when you are climbing stairs, going downstairs, your knee is working a lot. So if there's any deformity or small inflammation or disruption of the normal function, yes, you can get pain. And you can handle that pain by exercising. We have what we call knee strengthening exercises. We have the leg raises you can do when you're seated. They strengthen your quadriceps, and they tend to minimize the pain in the knee. If the pain is not going away, we can give you local NSAIDs where you can smear or apply over the knee or where it is paining. It also works well, and it can control the pain. So that one you can treat the pain in the knee. The other question was related to gut microbiome and arthritis. I don't know if all the people understand what they mean by microbiome. So you have bacteria. We have normal bacteria in the intestines, which we call the microbiome, or organisms which live on our body. And they influence a lot of our health. It could be in the mouth, it could be in the intestines, it could be elsewhere on the skin. So the germs or the bacteria on our bodies influence the inflammation. And regarding rheumatoid arthritis, we have noted that people who have a bacteria, there's a certain bacteria in the mouth. It is called Purposeful gingivalis. It has an enzyme which changes a certain protein, which looks like one of the protein in the synovium. And when the bacteria changes that protein, the body produces antibodies against that protein. Unfortunately, as it tries to get rid of that protein, it also attacks or destroys the similar protein in the synovium, hence leading to inflammation and a disease called rheumatoid arthritis. So yes, the bacteria or the germs in our body, especially the gut microbiome, can influence the types of arthritis we have. There are others which have been associated with spondyloarthritis. We have Reiter's syndrome. There are some bacteria, either in the urinary tract or in the GIT, which can also stimulate that kind of attack. So that is a big topic with a lot of science involved or explanations. I will leave it at that. So take care of make sure you have healthy germs on your body, not bad germs. Then the other one was related to eating ginger and garlic. Yes, we know that ginger and garlic have anti-inflammatory properties. You've heard people say, okay, if you eat a binzari, so turmeric, ginger, garlic, and other soursop, they all have anti-inflammatory properties. So when you take them, they kind of control the immune system. And if you have inflammatory arthritis, the swelling and pain will reduce. However, they can predispose other conditions like ulcers, especially if you're eating a lot or they are so concentrated, they can bring other issues like ulcers, as she has stated. So you need to work on a balancing act or a tightrope. So you need to determine which levels, how many spoons or how many cloves of garlic or ginger do you need without giving you heartburn or ulcers. So that is for you to determine. But just know that they will control the pain and swelling, but they will not take away the arthritis. So you may need other drugs to control the arthritis. I've talked about beans. Yes, beans and peas can increase the risk of uric acid in the body. So there are other vegetables which can also increase uric acid. So things like spinach, asparagus, or cauliflower tend to produce high levels of uric acid. So you need to be cautious as you eat them. Whereas we recommend them, you need moderation and find alternatives. For some people, yes. For others, it's okay. So you can only know that you have high levels of uric acid when you do a blood test. And we are starting to see, especially in people who treat heart conditions, they have started to prescribe drugs which lower uric acid levels in such scenarios. Then food supplements.
Dr. Philippa, could you?
I was trying to switch off another phone. So there are food supplements. There are quite a number, various forms, various constituents. Some have minerals, others have various joint-related ingredients. We've talked about osteocare, osteomine, osteoflex. There are many other joint health. You have seen healthy woman, healthy man. We have very many vitamins there. So there are very many food supplements. So usually with their supplements, and supplements just try to make sure that your body is receiving the actual recommended daily requirement for that specific ingredient or chemical. So if you are taking supplements, as long as they are not causing any problem, it's okay. Usually I don't stop them, but just know that they're expensive and they may not treat the actual disease. They are only food supplements. Use them if you must. If you're eating a healthy diet, then you don't need supplements. Then the other one was related to joint pain, related to kabotongo in the elderly. So there's a lot of, especially if you listen to radio, TV, various people are saying that all arthritis is due to kabotongo. Kabotongo is syphilis. Just know that by the time you get arthritis arising from syphilis, syphilis is sexually transmitted. It is a sexually transmitted disease which typically has 3 phases. And by the time it goes to your bones and joints, then you must be very sick. So don't believe everything you hear. Personally, I have not seen or treated a patient with overt syphilis disease or syphilis infection with arthritis. So not every joint pain or swelling in adults or elderly people is due to syphilis. Then the last one was related to physiotherapy using local herbs. Yes, it's okay as long as you have no allergies or you have no problems related to the herbs you are using. Thank you.
All right, thank you. The last comment was, can ketogenic diet relieve osteoporosis or control protein intake?
Pardon? It was a ketogenic diet?
Ketogenic diet relieve osteoporosis too, or control protein intake?
Ketogenic diet is mainly fat. We haven't used it in arthritis. I know we have used it in epilepsy, where the patient is given high amounts of fat. We literally feed the patient with epilepsy on fat, butter. I mean, you are trying to limit the protein intake and other things. You are giving lots of fat to minimize the carbohydrate intake or your total daily caloric intake, and you shift the body to produce ketones. Ketones are another breakdown product where you produce they are acids also. And they have been thought or suggested to kind of control metabolic or cardiovascular diseases, but no overt studies or prescriptions have been given to use them in controlling arthritis. I don't think they play a big role in osteoporosis, because for osteoporosis, your main ingredients is low levels of calcium and vitamin D. So if your intake of vitamin D and calcium are low, then the body is going to get that calcium from your bones, which are an easy source for the body, making your bones weak. So you need to remember that for women, every child you deliver, you give birth to, their bones come from your bones. So they kind of deplete your calcium and make your bones softer or weaker. That is why you see women tend to become shorter faster compared to men. Initially, you are either taller than your husband or your spouse, your children, but eventually you see you are becoming shorter. Your children are getting taller, and you start bending. That is typical osteoporosis. So restriction of carbohydrates. Carbohydrates are not a rich source of calcium and vitamin D. Vitamin D and calcium are rich in dairy products. So that's why I usually recommend, if there are no other contraindications, make sure you continue taking your dairy products, meat, milk. A glass of milk has about 500 milligrams of calcium. Your body needs about 1,500 milligrams per day. That is about 3 glasses a day of milk. Ice cream, yogurt, eggs, meat, those are the easiest sources of calcium for you, such that you don't develop osteoporosis. Ketotic diet will not. So continue taking your dairy, you take your milk. That's why you see for the US Western world or Europeans, you see they take a glass of milk before they go to bed because they need the calcium. We worry about the lipids, but you can control your lipids through other sources, exercise and eating vegetables or high fiber diet. So ketotic diet, no, don't use it. We know fasting is good, but it doesn't help with osteoporosis. I think that is all.
Yes,
Any
so hand over to the moderator. We have run out of time.
Okay.
So hand over to the moderator to conclude the session.
Thank you.
Thank you so much, Dr. Philippa, for handling the question and comment session. And once again, Professor, we've been made wiser and wiser, especially on the way we eat, our lifestyle. And at this juncture, I would like to ask Professor Pauline, I'm sorry, I've forgotten the other name, Pauline, to kindly give us a wrap up.
Pauline Biachika.
Biachika, Professor Pauline Biachika, to give us a wrap up of this session.
Wow. Thank you very much, Professor Mark Kadumukasa, for an excellent presentation that started off with osteoarthritis and ended up with so much other information on metabolic diseases. It has been a wonderful session, Professor Kadumukasa Mark. Thank you very much. the attention can be felt from the questions that participants have have asked. There were very many questions, very pertinent questions, and I'm sure many more still had many other questions to ask. But because of time, we have been cut short. The interest on this topic is overwhelming. I can only summarize saying that many of the things Professor Kadu has taught us this morning touch our lifestyle. Lifestyle is very important. I thank you very much, Dr. Kadama and Dr. Kadama and another Dr. Kadama and Dr. Javira for always setting up these very interesting sessions for us on Saturday morning on intentional aging. They are very important. Particularly this one this morning is very important, intentional aging, because Professor Kadu has touched on so many aspects of our lifestyle that if we do not think about and modify, we'll end up affecting our quality of life when we get to that age. Or for those who are already there, if you do nothing about it, you'll still get poorer and poorer quality of life. Sedentary lifestyle, he hinted on that. Let's all get up and do some form of activity, either in our backyard gardens or in gardens in the farms or in our offices or in the gym. Let's all get active. Let's stop this sedentary lifestyle because it doesn't help us at all. The ladies, the high heels, we love the high heels. He has talked about them. And the most important factor he has taught us this morning is to do everything in moderation. High heels in moderation, exercise in moderation, the diet in moderation, alcohol in moderation, and so on and so forth. I can't add anything more to what he has taught us this morning. So I want to thank you very much, Professor Kadu Mukasa, for an excellent presentation this morning. And I want to thank everybody who has been in the audience listening in. I'm sure we shall all pass this information to many other people that we live and associate with. And we look forward to the next session next Saturday morning. Thank you very much. And I wish you all a nice weekend.
Thank you so much, Professor Pauline Biachika. Our departing word is moderation. Please, for all those who have not been able to attend and you know they are there, direct them to our YouTube channel. The session will be up anytime, like after 1 week, we shall be able to view it on YouTube. And please remember to come back next in June, and last Saturday in June at 10 a.m. You've been such a good audience. You came on early. Thank you so much. Have a blessed weekend. Professor, thank you so much. We have no more words. Professor Biachika has said it all. Thank you so much. Thank you and bye-bye.
Thank you.
Yep. Bye-bye.
Thank you, everyone. Bye-bye.
Thank you.